Welcome to The Explainer. Today, we're looking at a pretty wild, high-stakes reality of modern medicine. You see, medications that are specifically designed to heal us can actually become life-threatening poisons if the dose is wrong. Drawing from the core material of lessons 47, 49, 50, 51, and 68, we're going to unpack the specific toxidromes and emergency management strategies for some of the most common and most dangerous medication overdoses you might ever encounter.
Okay, let's dive into this. Here's our roadmap. We're going to take a structured, fast-paced tour through 5 absolutely crucial categories of emergency toxicology. We've got anticonvulsants, thyroid medications, antihistamines and decongestants, anti-migraine medications, and finally, lithium. Let's get started.
All right, Section 1, anticonvulsants, seizures and sedation.
We're opening our toolkit with a truly fascinating contradiction. What happens when a seizure medication actually causes a seizure? I know, it sounds like a trick question, right? But this is the crucial paradox of anticonvulsant toxicity. Drugs like carbamazepine and topiramate are literally designed to control and suppress abnormal brain activity. But ironically, in a massive overdose scenario, they can actually induce refractory seizures and status epilepticus. Your primary tool for seizure control has suddenly become the cause. A key clinical sign you'll often see with these drugs is nystagmus. You know, those rapid, involuntary, kind of darting eye movements? The Salem tip mnemonic is a brilliant way to remember nystagmus-inducing substances. Notice the T and tip stands for Tegretol, which is a brand name for carbamazepine, and the P stands for phenytoin. Those two are major culprits for inducing severe nystagmus when a patient is taken way too much. And speaking of phenytoin, toxicity from this drug actually has a famous Frankenstein toxidrome. It's not just a cartoon exaggeration. It maps perfectly to real-world scenarios. Picture a 13-year-old coming into the emergency department with an incredibly ataxic, stumbling gait, slurred speech, and profound lethargy. At normal therapeutic doses, it's totally non-sedative, but in an overdose, they look and walk exactly like Frankenstein's monster. So when do emergency docs pull the trigger on ECTR, which stands for extracorporeal treatment, essentially dialysis for carbamazepine toxicity? Well, because it blocks sodium channels, an overdose can cause life-threatening dysrhythmias and refractory seizures. When those hit, or if a coma is prolonged and concentrations just keep rising despite supportive care, that's when we have to step in and physically filter the blood.
Moving right along to Section 2, thyroid medications, metabolism on overdrive. With these medications, synthetic hormones can trigger a massive systemic crisis. Let's look at a classic scenario. A 20-year-old consumes a month's supply of T4, but she presents to the ED a full 3 days later complaining of tachycardia and anxiety. Why the massive delay? It's a crazy quirk of human biology. T4 is mostly inactive. It has to undergo peripheral conversion in the body to become the biologically active hormone T3. So the toxic effects are ironically delayed while the body actively manufactures its own poison from the pills.
Once that conversion finally happens, the toxicity perfectly mimics a sympathomimetic state. We're talking extreme tachycardia, hyperthermia, and severe agitation. Because thyroid hormones dramatically increase beta-adrenergic tone, standard sedatives just aren't always enough to cut it. And this is exactly why beta-adrenergic antagonists, specifically drugs like propranolol, are absolutely critical here. They directly counteract that severe heart rate and the massive sympathomimetic symptoms.
Section 3, antihistamines and decongestants, the over-the-counter danger. You know, it is so easy to forget that widely available allergy and cold medications actually carry a remarkably low toxicity threshold, especially in kids. We can cleanly juxtapose two very contrasting toxidromes that come from the exact same pharmacy aisle. Massive antihistamine overdoses, think diphenhydramine, cause a classic anticholinergic effect. The patient is basically dry and dilated, highly sedated, dry mucous membranes, massive pupils, and retaining urine. But decongestants? They act as sympathomimetics. They cause intense CNS stimulation, extreme hypertension, and sometimes reflex bradycardia because the blood vessels are clamped down so tight. Managing a massive antihistamine overdose requires intense vigilance. We absolutely have to monitor the ECG because sodium channel blockade can widen the QRS complex and prolong the QTC interval, which can quickly lead to fatal arrhythmias. We use benzodiazepines for seizures, but notice this absolutely critical final step. Assess for acetaminophen co-ingestion. Why? Because these antihistamines are frequently packaged in combination cold and flu products.
You might successfully treat the antihistamine overdose only to tragically lose the patient days later to massive, undetected liver failure from the acetaminophen.
Okay, Section 4, anti-migraine medications. Vascular spasms. This is where medications designed to carefully, precisely constrict dilated blood vessels in the head go dangerously rogue throughout the entire systemic circulation. That brings us to ergotamenism, a syndrome of severe vascular insufficiency caused by ergot alkaloid toxicity. It causes profound peripheral vasospasm. The patient will have cold, highly painful, and even blue extremities. But the really insidious part is the timeline. Nausea and vomiting happen almost immediately, right? But the truly dangerous limb ischemia, where tissues are literally being starved of oxygen, that might not become clinically obvious for a full 24 hours after the overdose. It's one thing to talk about vasospasms as an abstract concept. It's another to see concrete proof of what these drugs can actually do. Take, for example, a CT scan showing an infarction, an actual area of dead tissue in the right kidney after someone used a triptan medication called rizatriptan. This proves that clamping down blood vessels systemically doesn't just cause pain, it starves vital organs, causing real, permanent damage.
Finally, Section 5, lithium, narrow therapeutic index.
This psychiatric medication is completely notorious. The therapeutic index is so incredibly narrow that the line between a helpful dose and a toxic one is razor thin. So the crucial point here is a rather surprising toxicological fact. If a patient swallows a whole bottle of lithium, activated charcoal, which is our usual go-to for overdoses, is basically useless. Charcoal simply does not bind to elemental metals. Instead, our primary tools are massive volume resuscitation with intravenous sodium chloride to force the kidneys to clear it, and whole bowel irrigation to flush sustained release pills right through the GI tract. And when those measures just aren't enough, we look at these crucial life-or-death thresholds for hemodialysis. Because lithium is heavily cleared by the kidneys, if kidney function is impaired and levels are over 4.0, we dialyze. If there's decreased consciousness or seizures, we dialyze immediately to prevent permanent brain injury. And remarkably, if the lithium level is over 5.0, we suggest dialysis even if the patient is currently sitting up and talking to you, because catastrophic toxicity is almost certainly on its way.
Oh, and there's one more magic number to keep in mind regarding lithium dialysis: 36. If we calculate that it will take more than 36 hours for the patient's lithium levels to drop below the safe 1.0 threshold naturally, the guidelines suggest initiating dialysis. We simply cannot leave the central nervous system soaking in toxic levels of lithium for days on end without risking permanent, severe neurological deficits. Well, we have covered a ton of ground today, from seizure meds that actually cause seizures to everyday cold pills that can completely crash the cardiovascular system. And I think it leaves us with a pretty provocative question. If everyday pills sitting right there in your medicine cabinet can turn from cures into absolute crises, how well do we truly understand the chemistry we rely on every single day? The line between therapy and toxicity is entirely dose-dependent. Thanks so much for joining me on this explainer. Keep asking questions, and I will see you next time.